Right. So, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. I've already been introduced. My name is Ahad. I'm a consultant nephrologist at Bahria International Hospital, Lahore. And before I start, I would just like to thank the organizers for giving me the opportunity to address this very, very important topic, which is looking into the management of resistant hypertension. Considering it is a very vast and extensive subject, I would just like to jump into my presentation. But before that, I would just like to share the disclaimer that the slide set that I will be sharing with you was provided to me partially by the organizers, and also I've included slides and asked permission from the Cleveland Clinic hypertensive unit in the United States of America, who I work very closely with. Okay, right. So a few words about hypertension. Everybody's aware of. It's a global public health issue. It's got a global prevalence of about 40%, that is in adults, and it is one of the leading primary cause of cardiovascular death. Here is actually a distribution of the world. More or less, it's 20 to 30% adult population does have high blood pressure, according to the WHO guidelines. That is all dependent on what you take as a target blood pressure. In this screen, it was taken as 140/90. In terms of Pakistan, the National Health Survey of Pakistan, whatever studies we do have available, by the definition of an adult, if you say that an adult is above the age of 16 years, the prevalence is 18% somewhat. But if the adult is taken, I mean, adults are actually 16 and 18 above, but if we look at the population above the age of 45 years, the prevalence of hypertension is 33%. Another study from Pakistan reports that every third adult in Pakistan above the age of 40 has high blood pressure, depending on what definitions you take. I keep on stressing the definition of hypertension, the reason being that that is actually a totally different subject and is up for debate. This is a very, very important slide. It has a take-home message to it that considering that if the BP is elevated by 10 millimeters of mercury in the diastolic or systolic of 20 millimeters of mercury, the risk, it actually doubles the cardiovascular mortality. An even more important slide is this one, in which it says that a reduction of 2 millimeters of mercury actually decreases the risk of cardiovascular events by 7 to 10%. But by what that I mean is that it is worth fighting for even a single millimeters of mercury, because that has implications on cardiovascular events. I would request someone to please unmute the mic, because clearly there is some mic is unmuted. Moving on to my next slide, that is refractory, and this is actually where the body of my presentation starts, and that is resistant hypertension. Now, this has been quite a troublesome term, and that is largely because there's a large number of antihypertensive drugs available in the market, and every physician has his or her own preference. So how do we define hypertension? And the issues have been that what is the level of blood pressure? Let's say, what is the target blood pressure we want to target, and what are the number of drugs at what dose? If we are unable to achieve that blood pressure, do we start saying that, label that patient that he or she has hypertension? So it has been quite an issue defining this term. And the first attempt that was made was by Gifford and Tarazi in 1978, and a very basic definition was put forward in which they said failure to control BP adequately with a good regimen, provided that medications are taken as prescribed. So a very vague definition if you sort of take into consideration the information we have nowadays. And the BP adequately, they said, was less than 150/100, which by no means is acceptable with the definitions of hypertension we have now. Even from the last year, the definition may be changing now, but the most prevalent definitions we do have in primary practice are what the JNC-VIII and the American Heart Association or the European Society of Hypertension told us, and they were targeting that, a target blood pressure of less than 140/90 if the patient does not have diabetes or chronic kidney disease, and if they do have that comorbidities, the level needs to be below 130/80. Even this slide may be outdated, especially with the SPRINT trial reporting, and that is a totally different debate that we can sort of address at a later date or time. So blood pressure targets, we're sticking ourselves to the definition of resistant hypertension. This is the most popular one still. that resistant hypertension is the failure to reach goal blood pressure in patients who are adhering to full dose of an appropriate three-drug regimen that includes a diuretic. What that essentially means is that if I've got a patient on a three-drug regimen, which is appropriate and in full doses, proper dosage, which includes a diuretic, and I am unable to maintain or control the blood pressure to a level of less than 140/90, I can label that patient to have resistant hypertension. But again, if that patient does have diabetes or renal disease, the target blood pressure needs to be 130/80. Fine. So once we've defined that, then what are the causes of sort of resistant hypertension? This is an excellent study, actually published in Annals of Internal Medicine, in which it showed that the most prevalent reason why a patient may have resistant or refractory hypertension. Refractory hypertension is actually a different definition, but we'll stick to resistant hypertension, is suboptimal therapy. So actually the physician is at fault that maybe we are not giving the appropriate regimen, number one. Number two, that we aren't giving enough dosage of that particular drug. And that is followed by non-compliance from the patient, secondary hypertension, white coat hypertension, and things like that. And this is actually a take-home message slide as well, that what are the possible causes that why would a patient be on three drugs of on appropriate dosage and still, the patient is unable to maintain the target blood pressure. The number one is patient resistance. The number two is physician resistance. Three is a drug interaction. Fourth is excessive salt intake, followed by white coat hypertension, secondary hypertension, or true drug resistance. And we will take each one of these in turn and what we can do as physicians to help our patients out in controlling our blood pressure. Starting off with patient's resistance. So patient's resistance is largely twofold. One is dietary, the other is pharmacological. From dietary point of view is that we sit the patient down in clinic, we say, listen, you need to cut down on the salt. But it's not easy. We can't just say cut down on salt. What does that mean? And I'll come to that after this slide. And we tell to them that, you need to reduce weight as well. In terms of pharmacological therapy, it just is that the patient doesn't adhere to the drugs, that he's not taking the drugs at all, or he or she is not following the prescribed dosing schedule. And I'll come to that as well. It's just shortly after a couple of slides. So starting off with excessive sodium. So we need to sit the patient down and say to them that they cannot have greater than 3 grams, or at best they need to decrease the salt intake by 2 grams. And one way I do this in my clinic is that once I've told the patient that, listen, you can't have more than 2 grams of salt in your diet per day. And if the patient comes back to my clinic and he's still not in the target blood pressure, so what I do is that I order a 24-hour sodium, urinary sodium, by the principle that whatever goes in must come out. So if I find more than, let's say, 120 milliequivalents of sodium in the urine in the 24 hours, that sort of tells me that the patient is taking more than 2.5 grams of salt. Each gram of salt contains 43 to 44 milliequivalents of sodium. You do a basic calculation. If the patient has greater than 120 milliequivalents of sodium in the urine, that the patient is definitely taking more sodium. And you just sit the patient down again, say that what he can do, reduce ketchup. He can't have these processed foods. Of course, adding salt to his food or her food is out of the question. Moving on to clues to poor patient compliance. It's just that you just ask the patient that, are you taking the drug? And if the answer is a little vague, that just gives you a clue that the patient might not be taking a drug, or if he's missing his appointments, that's another one. Another, small trick in the trade is just to ask them what color are his tablets? Are they tablets or capsules? And if you see that the answer is, a little hush-hush, so you can sort of say that, yeah, maybe I don't think that the patient is taking the drugs, and you start talking with the patient on those lines again. A more scientific way is that if the patient is on a beta blocker and he says or she says that he's taken a beta blocker in the morning and the resting heart rate is greater than 80, that sort of gives you an idea that the patient may not have been taking the drug as well. Same goes for a thiazide diuretic. It's known to cause hyperuricemia, sort of subnormal. I'm sorry?
Someone's mic is unmuted, so please mute your mic.
Yeah, please mute your minds, please. Thank you so much. Okay, moving on to physician non-compliance was, actually our study shows, was the main reason why we're not giving the proper dosage, not giving the proper combination of actually limiting the dose of the diuretics will cause might cause hypoglycemia, and diuretics in an OD dose is actually something that we need to discuss maybe in the question and answer session. So what is the appropriate regimen that we should be prescribing? So the 3-drug regimen, a very, very sensible way of doing that would be first to add a diuretic, and the second drug that we need to also consider adding is something that depresses the sympathetic nervous system. Now that could be a beta blocker, a combined alpha and beta blocker, or just an ACE inhibitor as well. And the third drug would be a vasodilator like hydralazine or a calcium channel blocker as well. So that is the first proposed regimen. We as physicians have all these regimens available to us, 1, 2, 3, and we use this as well. So oral diuretic, another sympathetic present blocker, actually taking the place of as a vasodilator. And the third one is an oral diuretic, a sympathetic and an ACE inhibitor as well. So we can pick and choose from all these 3 regimens, and these 3 regimens are pretty useful in my opinion because each and every drug has action and so what
sorry, Dr. Ahad, your sound is breaking a bit. So
drug that you have. Okay. All right.
It's okay now.
It's all right now. Okay. Sometimes I think maybe it's the internet connection playing up. Okay. Can you hear me?
Yes.
Okay. So fine. So what I'm trying to say is that let's say we give the patient a diuretic. What it causes is it makes the patient go to the bathroom a lot. It causes a negative salt and water balance. As a counter-regulatory mechanism, it stimulates the renin-angiotensin and aldosterone, and it sort of starts increasing the blood pressure. So the second drug that we need to add would be something that actually counteracts this problem, which is actually something that suppresses the renin-angiotensin system, which can be a beta blocker as well, or it can be just be an ACE or ARB. Same goes for a vasodilator as well. So this combination can really help if given in the appropriate dosage. Okay. Okay, so okay, here we are. So the next slide is that the third cause of hypertension is that we see these prescriptions very so often, and they've got all these drugs that cause hypertension themselves. And the most common one I see in my clinic is non-steroidal anti-inflammatory drugs. The patient is taking painkillers like diclofenac sodium, naproxen sodium. So we either need to start decreasing the dose, or we need to shift them to something, maybe a simple Panadol if that can help with the pain. Second most common thing that we see in my clinic is, because I am a nephrologist, is that injection erythropoietin, which we use for renal anemia, is notorious for causing hypertension. So we need to start looking at that dose. In our transplant clinic, and patients are being referred from the rheumatology clinic, cyclosporin and tacrolimus is there. And of course, illicit drug use, especially cocaine, which increases the norepinephrine secretion and decreases the uptake at the new postsynaptic junctions, is a major drug that we need to sort of address. So these were the main 4 ones I wanted to address. Pseudo-resistance is another cause of resistant hypertension, one of which is just that patient has a stiff brachial artery, especially seen in patients who have got peripheral vascular disease, and you can sort of do the Osler's maneuver and know that whether that is true or pseudo-hypertension. A sort of a clue in a patient who may have pseudo or hypertension or true hypertension would be that the patient reports that at home the blood pressure is fine, but when he or she comes to clinic and the blood pressure is elevated. Secondly is that you look at your end organ damage, look at the fundus, and there's no hypertensive changes, but you see the patient, he's got, at that time the blood pressure is 200/100. So if he or she doesn't have end organ damage, chances are that the patient has pseudo hypertension. Just a word about what is office hypertension, or what we call as white coat hypertension. It's just used to pressure response to office visits. The clues are that, as I said, there may be a disparity in the home and office pressures. If there's no evidence of target organ damage, that also gives you a sort of hint that it may be just it is just maybe something that is happening in the clinic. And of course, postural symptoms as well, in the sense that the patient comes to a physician and the blood pressure is 180/100. The doctor gives them a drug. At home, when they go home and the patient has a fall or is having postural hypotension, that you may want to consider the diagnosis of hypertension in that case, considering that clearly that may be something due to pressure effect of the patient's hospital visit. Okay, so what can we do to sort of eradicate white coat hypertension? Now, this is being practiced in the West. At least it's definitely being practiced in Cleveland Clinic and the UK. And what we do the automated office blood pressure. And in terms of what do we do? So when the patient comes into the clinic, I myself or my assistant or the nurse takes the blood pressure and we jot it down. Then we apply this automated office blood pressure device who records blood pressure at 2 minutes interval for 10 minutes and records it in the system. And I just leave the clinic. I ask the nurses to come out and I'll just say that, okay, just relax, I'll be back in 20 minutes. And lo and behold, this is something that we see, that the blood pressure that I checked was 180/76, but all blood pressure readings once I had left the room were actually this. So it just averages out, and that is one way of knowing this. And this was actually proven by this wonderful study published in the Journal of Hypertension, which showed that automated blood pressure device management was pretty similar to ambulatory blood pressure measurements, which can be quite tedious. Moving on to secondary hypertension. So secondary hypertension, you would suspect in anyone who is young, who's present with malignant hypertension, who's got target organ damage at a very young age, or has got, unprovoked hypokalemia and, symptoms or lab investigations that indicate a secondary cause. I'll just come to them. I think it's a too busy slide for you. So this is a battery of causes of secondary hypertension. I would not want to waste your time on this. I would actually like to bring your attention to these 5 things, which I consider in my clinic to maybe the major cause of secondary hypertension. So what do I do whenever I'm suspecting secondary hypertension? I just ask for 3 tests. I just ask for a RFT, serum electrolytes. I ask for an ultrasound, and I ask for a urine complete. If I'm really worried, in the ultrasound, I would actually go for a Doppler ultrasound of the kidneys to rule out renal artery stenosis, and also order a TSH. So these 4 tests would actually rule out the major causes of secondary hypertension, which is renal parenchymal disease, renovascular hypertension. If the patient has got hypokalemia, I would definitely suspect a primary aldosteronism, although that is not a rule of thumb. A pheochromocytoma is actually, it's pretty specific history, and a hypothyroidism or a hyperthyroidism is a secondary cause. For renal parenchymal disease, all I need to do is look at the creatinine, look at the CMD differentiation on the ultrasound, look at the kidney size, look if there's hematuria or proteinuria, and then probably I would request our primary physicians to refer to a nephrologist at an appropriate time. In terms of renovascular hypertension, an indication would, of course, be an abdominal bruit, which is not something that you hear every day. It's very, very rare. But what you can suspect for a patient who's got renal artery stenosis is that you have given them an ACE inhibitor and the creatinine and the potassium increases by 50%. Or on ultrasound, if you see that there is more than 1 centimeter differentiation between both the kidney size, is that when you start expecting renal artery stenosis, and it would be a good idea to refer to a nephrologist as well. Primary aldosteronism, as I said, if there's hypokalemia, you should definitely be thinking of it. In terms of sending off a test, a very good test to send off would be a plasma aldosterone level and a plasma renin activity. If it is greater than 30%, that sort of gives you an indication that the patient may have primary aldosteronism. Pheochromocytoma, it's episodic. The patient gives a sense of impending doom when all these catecholamines are being secreted in the body. The patient has headache, tachycardia, palpitations, tremors, and sweating. VMAs, we used to do urinary VMAs. I think they are pretty outdated now. So the best way to do is to do a plasma catecholamine and a 24-hour metanephrine level, and that sort of gives you the diagnosis as well. The treatment is largely surgical, and because we have to do a CT and locate where the pheochromocytoma is, and we remove it. I've already told you about the TSH level, a thyroid level, and we look at hypo and hyper, and we cure that, and the patient's resistant hypertension also goes away. So once we have done all of these things, we've assessed patient resistance, we've assessed physician resistance, we've looked at the prescription. It doesn't have any drug interactions. We've counseled about talk. We've ruled out secondary causes and type 4 hypertension. Then we start talking about true drug-resistant hypertension. And for these, now actually the surgical treatment of hypertension are also there, just like diabetes. And that is firstly BAT, which is the baroreflex activation therapy. It's just actually we don't do it in Pakistan to the best of my knowledge. What we do is that we implant a pulse generator and we stimulate the baroreflex. That is, we just increase the parasympathetic drive, and that brings the blood pressure. After Simplicity 1, 2, and now 3, we have results that renal denervation also works, that we just go up the femoral artery, and the interventional cardiologist or the nephrologist can do that. They just go up the femoral artery, enter into the renal arteries, and make these radio ablation burns 5 on each sides, and we denervate the renal artery, the sympathetic renal nerves. So this is a basic algorithm, which I've just already discussed. So we just follow this. One thing is that if we are unable to achieve blood pressure, it's difficult to achieve it, but more often than not, it will require more than one drug. More or less every study has shown that of resistant hypertension, the UKPDS, MDRD, with an average drug greater than 3 drugs to control resistant hypertension. And that is where the combination therapy comes in. And, a very, very good combination can be amlodipine and valsartan, and it's been shown that it affects across all blood pressures between 140 to 160, 160 to 80, or even greater than 180. Similarly, a combination of amlodipine, valsartan, and hydrochlorothiazide does wonders as well across all blood pressures, and more importantly, across all diverse patient subgroups, whether they're elderly, diabetic, or obese. I thank you for your time and patience.
So thank you, Dr. Haji Mohammed Ishfaq, for joining to the session. So we'll take your opinion after the second talk. So for the second talk, the topic is how we can manage the HFrEF with the new class RD with a case-based evidence. So for this, we have with us Dr. Ahmad Usman, who is currently head of Department Fauji Foundation Hospital and consultant interventional cardiologist at Army Cardiac Center, Lahore. So over to Dr. Ahmad Usman. Sir, you can please upload your presentation and start the talk, sir.
Thank you, Atisham. Assalamu alaikum, everyone. Let me just share my slides and then we'll get started. Is it visible to everyone?
Yes, Dr. Ahmad Usman, I can see your slides, so please go ahead.
Okay, so before I start, that was an excellent presentation by Dr. Ahad. I don't think so he left anything which was unanswered, and a very comprehensive presentation. So coming to my presentation, it's the role of Sacubitril and Valsartan in heart failure with reduced ejection fraction, and this is going to be a case-based presentation, and I'll be giving you my views related to a case that we treated. So this is the disclaimer, and coming to the history of the case, he's a 65-year-old gentleman who had ST elevation MI in 2019. He was a diabetic and hypertensive and had mildly deranged renal functions. On echo, he had an ejection fraction of 25% with a severe anterior wall hypokinesia. He was thrombolyzed with streptokinase, and subsequently his coronary angiogram was done, which showed quite a severe disease with left mainstem involvement along with double vessel coronary artery disease. I'll be showing you the coronary angiogram in a moment. So considering the fact that he had severe LV systolic dysfunction, we decided to go for a thallium viability scan before we embark on any intervention. So the thallium viability scan showed 6 out of 10 areas of LAD which were viable. So this was a go-ahead for us, and we did an angiogram. And afterwards, keeping in view that he had severe triple vessel disease and involvement of the left mainstem, he was advised bypass. But the patient, despite repeated visits to the cardiac surgeon and counseling by us, was unwilling for CABG. and we decided to ultimately go for a PCI. So he underwent PCI to left mainstem to LAD and circumflex. So this is the view. You can see that there's critical disease in the circumflex. There's involvement of the OM branch, the ostium, and there's critical disease at the ostium of the left LAD. So the condition, this scenario is worsened by the fact that he also had a chronic total occlusion at the mid of his LAD. Now, opening up of CTOs is quite a difficult endeavor, especially in patients who have severe LV systolic dysfunction. As the patient was unwilling at any cost to go for a CABG, we decided to open it up. So this is the LV function. You can see there's global hypokinesia with some sparing of the infraposterior wall and severe hypokinesia of the anteroapical area. After multiple attempts with different wires, we were finally able to cross the lesion with a pilot 200 wire. And then we stented across the lesion from this point till this point. And then we went for the circumflex. Now, in any other circumstances, I would have gone for stenting of the circumflex first and then gone for the LAD. But in this case, we were not sure that we would be able to open the CTO. So we decided to open the CTO first and then go for the revascularization of the circ, and then in the last from the left mainstem into the LAD. So we decided to do a balloon inflation in the ostium of the obtuse marginal branch over here, because we were afraid that once we stent across the OM branch from the origin of the circumflex, it would be jailing the OM branch, and that might pinch the OM branch. So we decided to do go for a POBA, which is the ballooning of the ostium of the OM branch. And then we stented across the OM branch, covering the entire lesion starting from the proximal area of the circumflex, going to the distal. And then we stented across the circumflex, going from the left mainstem into the LAD and overlapping the distal stent that we had already placed into the LAD. So this is the final picture. You can see that the circ is looking good. The left main to LAD is also good. There's a slight pinching of the OM branch, but that was as expected. So the patient, after his PCI, he showed some improvement for a few months, but then gradually he again started coming back to us with symptoms of shortness of breath, which we tried to manage medically. Over the course of a year, he had multiple admissions in hospital for shortness of breath, and which required IV diuretics and bed rest, and he would go home and come back again after a few weeks with the same complaints, and we had to readmit him, keep him there on IV diuretics. Again, he would improve, we would send him home. So this became a routine. He had pedal edema, started losing his appetite, and he was getting very depressed because of the fact that he was unable to do the daily chores of his life, and his quality of life was getting very hampered. He was in NYHA functional class of 3. So after his PCI, he showed some improvement, but again started to have a shortness of breath. We try to manage that medically, giving him the GDMT. But over the course of next year, he had multiple admissions, and he required diuretics, strict bed rest. He would go home, come again after a few weeks, and this continued to go on and on. And his quality of life was getting seriously hampered. So we decided to switch him to Uperio. His investigations did not reveal anything significant apart from the fact that he had slightly lower GFR, which was 40 ml per minute. Still not that low, because if it had been less than 30, we might be more concerned. So his chest X-ray revealed signs and symptoms of congestion. Echocardiography revealed inferior wall hypokinesia, a functional MR, and the infraposterior wall was okay, but severe hypokinesia of the interior wall, IVS, and the apex was there. So his medications included aspirin, statins, PPIs, carvedilol, diuretics, as well as aldosterone antagonists, ARBs, even on ivabradine, digoxin, and his usual medications for his diabetes mellitus. So we decided to switch him to Uperio. We started on a lower dose, considering the fact that he had slightly lower GFR. So we started on Sacubitril 24 and Valsartan 26, made a total of 50 mg, giving him twice daily. Again, the apprehension was his slightly deranged renal function test. The actual dose modification is not there unless the GFR is less than 30 ml, but still we decided to stop with a lower dose and up titrate it later on. So as per the protocol, we up titrated the Sacubitril to 49 and Valsartan to 51, which made a total of 100 mg, and gave it to him twice daily. And over the subsequent weeks, he tolerated it well. Now, in the initial period of starting the drug, there was some hypertension, but somewhere between 90 to 55 millimeters of mercury. And we did consider stopping the drug, but then over the next couple of weeks, his hypertension improved. So that was reassuring for us, and we decided not to stop the drug and continue with the same drug. And after another 4 weeks of treatment with this, we up titrated it to 100 mg PD. So his ejection fraction improved from 25 to 30%. This was done 6 months from starting of the drug, and again, I repeated it about a couple of weeks before. So it was now at 30%. And his functional class has improved from class 3-4 to class 2, which is again a very, very significant improvement. He has regular follow-ups with me every 4 weeks. His clinical symptoms have improved. There's no orthopnea. He says he's able to go to the mosque 5 times a week. He's able to enjoy his different hobbies like gardening. His sleep has improved, and he enjoys a much more restful sleep now. His appetite has improved, and all of this has translated into a decrease in his depression. And his recent labs showed there was a marked improvement in his NT-proBNP, which has decreased to almost 50% of his initial value. So the conclusion for this would be that he is he's quite stable now with NYHE class 2. He's drainage free, and it's been more than 6 months now, and he's tolerating the 100 mg BD dose of Uperio quite well. The good thing is his doses of diuretics has been reduced, and there's improvement in the quality of life and walking distance. He is not having any serious adverse effects apart from the initial transient phase of hypertension that he developed on starting the drug. So coming back to the heart failure and its causes and how we're going to deal with it. So heart failure world over is escalating. The numbers are escalating, and patients, especially who are in class 2 or 3, they have significant dips in their clinical situation. So I was saying that heart failure is escalating, and the reason why it needs to be tackled is because of the considerable mortality and morbidity it has, the financial trouble, the financial burden it is on the hospital and in the institutions, and the effect on patient's life. So patient's quality of life is very important, and if that is not there, then the patient is not happy. So it needs to be tackled, and like Professor Ahad said, there were not adequate pharmacological therapy for that. So the mortality, as you can see by these graphs, is quite high for patients in class 1, 2, and more NYHA classes. So this was the guideline of 2017, which initially said that we need to start patients with either an ACE inhibitor or ARB in conjunction with the beta blocker. And if this was not adequately controlled on these, then maybe we can consider an ARNI. So this was in 2017, and there have been different trials since then, the latest being the PROVE-HF, and which has changed the things in the scenario. So, and there has been a latest update this January of the American College of Cardiology, and which has now recommended that ARNIs should be and can be used as the first line for heart failure. as well as ACE inhibitors and ARB. So this is a significant jump from step 3 to step 1 for ARNIs. So one of the reasons that they decided to shift it as a first-line drug was there was a considerable improvement in cardiac all-cause mortality, and significant decrease in the hospital admissions, and an improvement in the patient symptoms if they were started on even patients which were naive to RAAS inhibitors. So this was all seen in the PROVE-HF trial. So now the ACC recommends that ARNIs or ACE inhibitors or ARBs can all be started as first-line drugs in conjunction with a beta blocker. Now these beta blockers, again, a word of caution, should only be those which have been tried and tested by trials, which include carvedilol, bisoprolol, and metoprolol succinate. So these are the 3 beta blockers that need to be given for heart failure. In conjunction with these, then you can also add aldosterone antagonists, and there's a significant new player in the game as well, which is the SELT2 inhibitors. Now, this has also shown a significant improvement in heart failure in patients who are diabetic and in patients who are not diabetic. So this is a new inclusion, and this is also a very promising drug. In addition to that, we can have loop diuretics, we can have hydrolysine, and we can also have evaporatine. Now, there has been no prognostic benefit of loop diuretics, but still this is given. This is one of the choices that we have. Also, there is no proven or very significant trial about use of digoxin, but still that is also there, an option for the heart failure patients. So these are the indications for ARNI. So the recent game changer that has come up is the PROVE-HF trial. We had the Paradigm trial before, which was the largest trial ever to be conducted for heart failure patients. Then there was the Pioneer. Now the Paradigm was a head-to-head trial of comparing Sacubitril and Valsartan to enalapril, and which showed again a very significant improvement. The Pioneer had targeted those patients who were acutely decompensated. So that was not there in Paradigm. So Pioneer targeted those, and now PROVE-HF has shown that there's a significant lowering of the NT-proBNP levels in patients who were given Sacubitril Valsartan, and this has led into the translation of improved symptoms, clinical improvement, structural and functional improvement in the patients, and as well as the lowering of the natriuretic peptides. So this PROVE-HF shows is has completely changed everything, and that is the reason this has been included as a first-line drug. So the objective of PROVE-HF was to determine whether NT-proBNP changes in patients who are treated with Sacubitril Valsartan and whether these changes correlate in clinically significant improvements or not. And the endpoints were at 6 months and 12 months, and that showed that there was significant improvement in the clinical symptoms. There was a drop by more than 50 to 70% in NT-proBNP, and there were improvements in the functional capacity of the heart, and the parameters being the LV and systolic volumes, the LV and diastolic volumes, the LA pressures, and of course the ejection fraction. So these were the endpoints, and all of these were met. So this is again the key points: inclusion and inclusion of the PROVE. And the summary of results was that there was a significant improvement in the echocardiac measures of the cardiac remodeling, and there was an improvement in the ejection fraction, as well as the reduction in the hospitalizations and improvement in the patient symptoms. So how should we start with Uperio? Well, it comes in different formulations. There's the 24 and 26 milligram, there's the 49 and the 51, and of course there's the 97 and 103 milligram, which again are all given in a BD dose. And Uperio is the first in class of the ARNIs which has been recommended for this. So the do's and the don'ts of Sacubitril Valsartan: don't start it along with an ARB, ACE inhibitors. So there has to be a discontinuation of the ACE inhibitors, and there's a washout period of 36 hours before you can start it. And this is because of the angioedema that may happen. So one of the don'ts is don't use it in conjunction with an ACE inhibitor. Also, not indicated in pregnancy. If the patient has a previous history of angioedema, this is contraindicated. So one of the most common side effects before of using this is hypertension. And of course, there's deranged renal function. So the patient's GFR is less than 30 ml per minute. You need to do a dose modification. Also, if the patient is unable to tolerate, that has to be also kept in consideration. And if the need be, you can hold the drug for some time. And if the patient starts tolerating, you need to up titrate it to the maximum doses that are recommended. Now, one of the reasons I would say that this has not been used till now is because patients are reluctant to use it because of the cost. The physicians are unaware of a lot of our physicians. It's not, the information is not that prevalent, and of course there are concerns about the safety. So now with the latest updates and the focus updates of the American College of Cardiology, it is quite evident that it can now be used as a first-line drug. There are no serious adverse effects. Of course, as with any drug, there are some adverse effects, but not so much. And the benefit definitely outweighs the any adverse effects that there might be. So this is probably the crux, that we need to start it in patients as early as possible.